Welcome to This Explainer. Today, we're diving straight into a medical investigative journey, covering one of the most stressful, high-stakes scenarios you can face in gynecology and radiology, post-pregnancy ultrasound findings. When a patient comes in with bleeding after pregnancy, the images popping up on that screen can look incredibly alarming. But as we're about to see, jumping to the wrong conclusion can actually be just as dangerous as missing the diagnosis entirely. So here's the core problem we're tackling. You're looking at a patient who has this highly vascular, tangled web of vessels in the uterus. Now, is this just normal healing, or is it a dangerous anomaly? Confusing a normal, resolving physiological process with a highly dangerous structural issue can lead to life-threatening hemorrhage. Or, on the flip side, it can trigger entirely unnecessary, high-risk interventions like a DNC or even a uterine embolization. Getting this right is absolutely crucial. Here's our detective roadmap for today. First, the terminology trap. Second, decoding EMV. Third, the EMV spectrum. Fourth, EMV versus acquired AVM. And finally, we'll cover mimics and management. All right, let's jump right into part one, the terminology trap, and why words actually matter in radiology.
For years now, there's been this widespread and frankly incredibly dangerous habit of using the terms EMV, which stands for enhanced myometrial vascularity, and acquired AVM, arteriovenous malformation, totally interchangeably. Listen, they are absolutely not synonymous. Calling prolonged post-pregnancy vascularity and acquired AVM might trigger an unnecessary uterine artery embolization or a high-risk surgery. In reality, true congenital AVMs in the uterus are exceedingly rare. What we often label as an acquired AVM post-pregnancy is actually just a normal healing process taking a little longer to resolve. Moving on to part two, decoding EMV on ultrasound, our prime suspect. Let's break down this definition. EMV is basically focal myometrial hypervascularity located right where the placenta used to be. You see, during pregnancy, maternal vessels are heavily remodeled into this high-velocity, low-resistance circuit to feed the baby. After pregnancy, these dilated vessels are supposed to regress. But when they don't do it immediately, they leave behind this lingering hypervascular echo. And, well, that is EMV. Our guide for today's explainer is a fantastic, definitive review paper from abdominal radiology. They're really doing the heavy lifting to standardize exactly how we recognize, describe, and treat this phenomenon, moving the field away from outdated and risky terminology. Up next, part three, the EMV spectrum. Are we looking at normal healing or a pathologic delay? Notice the fascinating visual progression we often see with this. At 1 week post-abortion, you might see tons of red and blue color Doppler signal. It's super vascular. But just 1 week later, that vascularity has spontaneously decreased. That right there is physiological EMV resolving totally on its own. Now, if this vascularity lingers abnormally long, it might represent subinvolution of the placental site, or SIPS. But remember, SIPS is ultimately a histologic diagnosis made by a pathologist under a microscope, not just an imaging call made by a radiologist. And here's another key stop on the spectrum. Retained products of conception, or RPOC. This is a totally different vibe. Here, you'll see a cluster of tortuous vessels centered right within a visible tissue mass inside the endometrium. And typically, the endometrium here is thicker than 10 millimeters. EMB combined with an endometrial mass is your classic presentation of RPOC. Just a quick side note, though, a positive beta-HCG blood test doesn't automatically mean RPOC is present, because those hormone levels can normally take months to drop anyway. All right, part four, EMV versus acquired AVM. Spotting the red herring. Comparing these two side by side really reveals some stark, dangerous differences. On one hand, we have EMV. It's rooted in pregnancy, it's physiological involution, and it very often just self-resolves. On the other hand, we have the true acquired AVM. This bad boy usually stems from trauma or an iatrogenic injury, like a previous DNC. Pathologically speaking, an AVM is a completely disorganized network of arteries and veins that lacks a normal capillary bed. And because there's no capillary bed to slow the blood down, any surgical interference, like attempting a DNC to clear what you mistakenly thought was RPOC, carries an unbelievable risk of sudden, severe hemorrhage. When you look at ultrasound images of a true acquired AVM, you'll see this serpiginous, tube-like appearance in the anterior myometrium on grayscale and marked, aggressive vascularity on color Doppler. But here is the massive kicker. On ultrasound alone, this looks virtually identical to EMV. They both have that high-velocity, low-resistance flow. So how do you actually tell the difference? The patient's clinical history is your absolute best clue.
Have they had heavy bleeding? Have they had prior uterine instrumentation? You gotta ask. Now, when ultrasound just isn't enough to give you that total confidence, catheter angiography steps in as the gold standard for diagnosing a true acquired AVM. It perfectly highlights the arterial supply and early venous drainage. In actual clinical practice, though, this is usually done right as the patient is literally heading into endovascular treatment to stop the bleeding.
So, what happens when ultrasound leaves diagnostic uncertainty and the surgical team is itching to do a DNC for mild bleeding? Well, non-invasive tools like MRI and MR angiography step in brilliantly here. You have to be absolutely sure there isn't an AVM hiding in there. MRI can clearly show enhancing tissue in the endometrial cavity without the early venous drainage of an AVM. That confirms it's just RPOC with EMV, which gives the surgical team the green light to proceed safely with the DNC.
Finally, Part 5, Mimics and Management. Let's close the case. Okay, you have to see this dramatic yin-yang swirling pattern on the color Doppler. It's a beautiful image, but of a highly dangerous scenario. That is turbulent, swirling flow inside a blood-filled collection communicating with a damaged artery wall, very often seen after a C-section. It's a pseudoaneurysm. Spectral Doppler will show a distinct to and fro waveform. If you mistakenly brush this off as just physiological EMV, this pseudoaneurysm can enlarge and ultimately rupture, causing massive, massive bleeding.
There are other shape-shifting accomplices out there too. Think about infections like myometritis or endometritis, which cause diffusely increased vascularity, not focal. Or even scarier, neovascularization from a malignancy, like an invasive molar pregnancy or an endometrial neoplasm. This is exactly why correlating the imaging with the clinical history, like a fever or rising beta-HCG levels, is absolutely essential. You literally cannot read these ultrasounds in a vacuum.
So what's our actual management blueprint? Well, it's highly individualized. Step 1. If the patient is asymptomatic, we manage expectantly. Physiologic EMV often just resolves on its own. Step 2. If there's persistent bleeding and visible retained products, a DNC or uterotonic meds might be the ticket. Step 3. For severe hemorrhage or a confirmed acquired AVM, uterine artery embolization, or UAE, is the frontline treatment to stop the bleeding safely without open surgery. And Step 4. Hysterectomy remains the absolute last resort if the bleeding simply cannot be controlled. There is one very important special caveat we need to cover. If you see EMV at the site of a prior cesarean scar ectopic pregnancy, you need to be on high alert. Recent evidence suggests this might not just be prolonged EMV, it could be a precursor to placenta accreta spectrum, or PASS. If you see a residual mass with avascular lacunae and high flow, embolization alone just isn't going to be enough. Surgical intervention is going to be required. The authors of this review leave us with a really powerful reminder. Our words directly dictate the treatments our patients receive. Calling a normal physiological healing process a malformation sets off a massive chain reaction of clinical panic and invasive procedures. Clarity and precision in our language literally protect the patient. Which leaves us with this final thought. The next time you're reviewing a scan and you see a tangled web of post-pregnancy hypervascularity, are you going to reflexively call it an AVM? Or will you stop, look at the timeline, look at the beta-HCG, and ask what the history is really telling you? Because the difference between those two paths could mean absolutely everything to that patient. Thank you so much for joining me on this explainer, and keep asking the right questions.